Thank you everyone for joining us for today's CTSC Distinguished Speaker Series. I'd like to take a moment to introduce our speaker for today, Dr. Doriane Miller. She's a professor of medicine at the University of Chicago, the director of Center for Community Health and Vitality, as well as the Vice Dean of Community and Divisional Values of the Biological Science Division at the University of Chicago. She's also a member of the Community and Collaborations Cluster of the Rush University of Chicago Institute for Translational Medicine. She's provided care to under-resourced urban populations for more than 30 years, and she's also served as the project director for several studies that are designed to augment care by promoting collaboration among physicians, patients, and families. Under her leadership, physicians, educators, and community members work to improve population health outcomes for residents on the South Side of Chicago through community-engaged research, demonstration and service models. Dr. Miller received her medical degree from the University of Chicago and completed a primary care internal medicine residency and general epidemiology fellowship at the University of California, San Francisco. Today, Dr. Miller will be discussing the role of community connections in advancing translational science. So with that, I will turn it over to you, Dr. Miller.
Thank you so much, Dr. Ritter, and it's an absolute pleasure to be with you today over Zoom. Wanted to take the opportunity to just talk a little bit about some of the work that we're doing here at the University of Chicago in the area of community connections, but specifically to link that work to the 7 translational sciences principles. And so I'll provide that information as a bit of grounding, and then also to just share a little bit of information with you about where we happen to sit within the city of Chicago. I'll ask you, if you would please, if you have any questions, to please put them in the chat, and I'll take questions at the end. I'll leave my slides in presentation mode, and so I won't be able to see the chat during this time. Just my CME disclosure form. I am not receiving any or received any support or funding from any commercial interest. And the 2 grants that I'll mention in this talk, including the Institute for Translational Medicine and also the Chronic Conditions Engagement Network, are posted here. For those of you who are doing work in this area, you're probably fairly familiar with the translational sciences principles from the National Center for Advancing Translational Sciences. In our organization, we sometimes call these the badges. And I think that the visual representation of these, I think, are very important in terms of really imprinting upon us as scientists and as investigators what's needed in order to help to promote science across the translational spectrum. The ones that I'm going to concentrate on for this talk include focusing on unmet needs, boundary crossing partnerships, and also creativity and innovation. And the 2 examples that I'll describe a little bit later in my comments will focus on how we've been able to address some of these things through the Rush University of Chicago Institute for Translational Medicine. However, for those of you who are a little less familiar with what's intended by these particular badges, I'll go into that in a little bit more detail, and then after that we'll follow on with who we are as the Institute for Translational Medicine. So in the area of unmet needs, here are just some example approaches, and this is information that's taken directly from the NCAT's website. What do we see in terms of scientific needs that is contributing to research advances in under-investigated areas of science, or scientific questions that might present with unique research challenges or even disincentives? And then also in the area of patient and population health needs, to think about research that develops solutions for unmet patient and population health needs, and frankly tailored to the needs of the patient and the populations that are being served. Utilizing boundary crossing partnerships, cross-sectoral partnerships, are something that's incredibly important in terms of the work that we do in helping to promote translational sciences. And these cross-sectional partnerships include government, other universities, and also industry, in order to leverage the varied expertise and resources in order to accelerate translational progress. And this is something that is done through an evidence-based approach. In terms of the area of patient and community engagement, and that's the area that I primarily sit in my work at the Institute for Translational Medicine, I look to involve impacted patients and communities as research collaborators in order to advance translational research across the continuum. And again, doing this from the perspective of evidence-informed practice, as well as looking at ways in which we can enable through the organizational environment, not only to enable, but also to incentivize these boundary crossing partnerships through leadership, through policies within our organization, and also through recognition and reward systems. And I'll talk a little bit about that as I talk about how we do this work at the Rush University of Chicago Institute for Translational Medicine. And then finally, creativity and innovation, not just in the area of research design and implementation, but looking at ways in which we can look at some of these paradigms that can be generalized in a way across multiple initiatives, diseases, and conditions. When I talk about the Chicago Chronic Conditions Engagement Network, that will be an example of that. And also in the area of research processes and structures, looking at ways in which we can not only develop innovations in research, but also to teach in this area and to facilitate and support the quality and impact of our research, and to do so through creative innovations and policies that encourage not only encouraging these innovations, but they don't penalize failures. So, who are we in the Institute for Translational Medicine? We were established in 2007 under the NG, the National Institute for General Medical Sciences, later turned into the National Center for Advancing Translational Sciences. And so we were funded through the first round as an individual institution at the University of Chicago. However, with the implementation in our second iteration of ITM, we changed to a multi-principal investigator structure. And so Rush University and the University of Chicago are the two principal organizations that are attached here. However, we have 4 partner institutions that we work with, and you can see the symbols up above in my slide there, including the Loyola Parkinson School of Health Sciences and Public Health, Endeavor Health, which is a collection of smaller community hospitals that are also academic training hospitals, and they also have a research institute associated with Endeavor Health. We partner with the Illinois Institute of Technology, and although the Illinois Institute of Technology does not serve patients in the classical sense, but they have a very robust program, particularly in the area of community engagement and community engaged research. And then finally, Advocate Aurora Health, which is another partner that works with us, which is a faith-based organization that not only has a presence in Northeast Illinois, but also Southeast Wisconsin, as well as a national presence as well. And so these are the partners that we work with through the Institute for Translational Medicine. This is our mission statement for the Institute for Translational Medicine, and this is taken from our ITM 3.0, which is to assemble, integrate, and create the intellectual, administrative, and physical resources required to catalyze research and research training in the clinical and translational sciences. We train university scientists and healthcare providers, as well as stakeholders from concerned communities. And I highlight this here because I'll talk a little bit more about how we do that in the 2 examples that I provide a little bit later. And we do this work together to determine the biological, behavioral, and social determinants of disease and illness. We develop and test interventions that are directed toward those mechanisms. But this is the thing that I think is really critical to the way that we do this work. We achieve these goals in a way that's rigorous, efficient, ethical, respectful, but also responsive to our community's priorities and values. And so the examples that I give in just a moment, you'll be able to get a sense of how we do this work within the Institute for Translational Medicine. We really engage community throughout the research life cycle. And so as you can see in this diagram here, that community is actually at the center of how we do this work. And not only as you take a look at the outer circles here, that we do it through not only inspiring interest in the work from community, but we also do team science training and community engaged research. We have communities members involved in research design, as well as the review of funding opportunities and peer review of applications. And we also have community members involved in terms of the implementation of research projects and the dissemination. As you can see on the outside of the circle, I've got a lot of titles that are surrounding that, including things that we do through the Institute for Translational Medicine, including the Sociome Data Commons, our pilot award program, the Chicago Chronic Conditions Engagement Network that I'll talk a little bit more in just a moment, including some of the work that we've done through our inquiries through town halls, and then another program that I founded through the Institute for Translational Medicine in 2010 called Community Grand Rounds. But before I go into this information in greater detail, I want to just give you a little bit of a taste of where we are in Chicago and the communities that we serve. But before I get to that, and apologies for this, just a few examples of how we are involved with ITM and community engagement. We have an overarching program called the Community Advisory Review Council, which consists of members that represent all of the ITM partners geographically in the Chicago area that are involved in the review of grants and applications to our pilot awards program. We strongly encourage and advise on external advisory boards for programs such as the Sociome Data Commons and others to have external advisory boards and community representatives in those projects. We also have project-specific advisory infrastructures in which I'll talk about this specifically around C3EN, which is the Chicago Chronic Conditions Engagement Network, as well as Community Grand Rounds. But in addition, and I think that this harkens back to the information that I shared around the importance of education and training in this space, we provide content for our early stage investigators around how to become proficient in community engagement and how to approach community engagement in a way that's ethical and respectful and responsive to community needs through our summer program and outcomes research training. We also have a series of lectures through something called ITM Grand Rounds, in which we provide information with outside speakers on the work that they're doing in the area of community engagement. And so we not only look at what we're doing as a Chicagoland institution, but also what others are doing in other parts of the country. And then finally, something called EPOR, or the Essentials of Patient-Oriented Research, in which we provide this content. Now we'll get to a little bit about Chicago. So Chicago demographics, we too sit on a great lake within the United States. We sit on the southwestern shore of Lake Michigan. We've got a population of about 2.7 million people, and although we're oftentimes referred to as the second city, and for those of you who have been here before, you may have gone to the Second City Improv Company, we're actually the third most populous city in the US. We've no single majority population within the city of Chicago, and you can see the breakdown in terms of race and ethnicity here on this slide. But we're also known as a city of immigrants and neighborhoods. If you meet anybody from the city of Chicago and they talk about Chicago proper, they'll say, I'm from Pilsen, I'm from South Chicago, I'm from Humboldt Park, I'm from Woodlawn, because really people have a very strong affinity for the neighborhoods and their communities. In the data that I have here is taken from the 2020 census, and there's actually been some changes in terms of demographics and population shift in that. In the 2010 census, about 20% of our population lived before the federal poverty line. That number has dropped down to about 17%, along with actually a shift with a decrease in the number of African Americans that live within the city of Chicago, and some out-migration that I'll talk about in a moment as we talk about some of the issues within the city. This is a map of the south side of Chicago, the city of Chicago, and the area that you can see located in gray is the area that's considered to be the primary service area for University of Chicago Medicine. In comparison to the 2010 census, in which we had about 810,000 people living in this area, this number has dropped down to 752,000 people, with some growth in the north side of the city, actually. And even though, as I mentioned before, that we have no majority of population in terms of race or ethnicity within the city of Chicago, that you'll see here that actually on the south side of Chicago, that it's primarily a Black or African American population that lives in this area. And you'll be able to see this, I think, in a little bit sharper relief with the slides that I'm going to show you in just a moment. This is a slide that was generated by the University of Chicago's Geographic Information Service based on data from the 2010 census. And although the numbers of people have changed a bit in terms of the areas where people live, determined by race and ethnicity, really has not changed. Any color that you see on this chart means that the population living in that community is at least 50% or greater of that specific race or ethnicity. On the legend that you can see in the lower left-hand side of your screen, anything that's in any shade of pink or red is Black or African American. Any shade that is in blue is the white population. Any shade that is in either yellow, ochre, or orange, it's kind of an orangey amber color here, is the Latinx population. And then any shade in green that you see is the Asian population. It's a little narrow strip that you can see in the middle of your screen there, area 34. Chicago is characterized by 77 distinct community areas that were determined through studies done long ago by the University of Chicago's Department of Sociology. Any area that's shaded in white, that there is no majority population in terms of race or ethnicity. So to give you a sense of where I happen to be here on the south side of Chicago, this is area 41, which is the Hyde Park community here, where the University of Chicago is located, where there is no majority population. But as you can see here on the south side of Chicago, and also demonstrated that in the slide that that preceded this one, that we are surrounded by a primarily African American population here in our primary service area, which goes up to about this area here, and then out to the side here, and then down and around. So again, bounded by the lake or the Indiana border here to the south and the southeast, the city limits here, and then over on this side here. The next slide that I'm going to show you is a slide that was developed by the Chicago Department of Public Health, based on American Community Survey data, 5-year estimates, called a hardship index. And these are the communities that are characterized by crowded housing, high poverty rates, unemployment, adults without a high school diploma, and then high dependency rates. That is, people who are either under the age of 18 or over the age of 64, thinking that people who are over to the age of 64 characteristically are not going to be in the workforce, as well as per capita income. The darker shades of purple are the areas that have a higher hardship index. And so again, I'll point out area 41 here, which is where the University of Chicago is located. And then the community just to the north of it, which is the Kenwood community. But again, think about that graph that I showed you before in the area that I'm outlining here, which is our primary service area, in which there's a tremendous amount of poverty. Indeed, the neighbors that are just to the west of us in the Washington Park area has one of the highest hardship indices that you can see here. So take a mental snapshot of this particular graph, because I think that as we talk a little bit about what we'll see in the maps to follow, you'll see some connections there. Chicago Childhood Opportunity Index map. So although I'm an internal medicine physician and I care for only adults, when we think about the trajectory, particularly of health, we also think about what takes place in these communities and the opportunities for children. The headline here is that 48% of children in Chicago live in low child opportunity areas. And then the listing of the communities that you see there are the ones with the lowest child opportunity areas. Although Area 41 is not numbered on this map here, this is where it's located here on the south side of Chicago, where University of Chicago is located. But you can see again that either the darkest shade of blue or shades of red are the communities that are served by U Chicago Medicine here on the south side of Chicago. And these areas were characterized by high school poverty rates, adult high school graduation rates that are low, lacking opportunities for early childhood education, and then issues around health and the environment, and also the social and economic issues that you saw that really characterize the neighborhood hardship indices that you saw on the preceding slide. Some of you who do work in the area of gaps in healthcare may be familiar with the maps that were generated by the Center on Society and Health from Virginia Commonwealth University. This is a work that was funded several years ago by the Robert Wood Johnson Foundation. And this is just I think, in sharp relief, tells you what kinds of gaps we see in terms of life expectancy within the city of Chicago. So I mentioned Washington Park and life expectancy, or the gaps in terms of economic deprivation for that community. So University of Chicago happens to be over in this area here. They couldn't fit this particular legend here. It actually should be between the red line and the green line here. But these are our neighbors that live just to the west of us here in Hyde Park. Take this life expectancy and comparing this to folks that live up on the north side in the Gold Coast and Streeterville area, of a life expectancy difference of about 16 years. Now I'm showing this to you as a historical reference because I actually have in the following slides some updated information for you regarding life expectancy in a number of Chicagoland communities that you'll be able to see in just a moment. But just to keep this in mind. The distance between, when we think about the life expectancy here between our Loop, Streeterville, Gold Coast area and the area that's here on the south side of Chicago is about 8 miles, just in terms of the distance traveled along this rapid transit line. This is information that was just presented through the Chicago Department of Public Health as a part of their Healthy Chicago Zones information. So the Chicago Department of Public Health breaks up the various areas of the city in 6 Healthy Chicago Zones. And you can see here averages for the northwest side of the city, north central, west, southwest, far south, and near south sides of the city. And also, as I mentioned, the 77 Chicago areas here. The legend here for life expectancy at birth is here on the side, which either the darkest color of gray or black being the shortest life expectancies. Area 41 here, as I mentioned before, is Hyde Park in the University of Chicago. And as you can see here, and as I outline this area, you can see that several of the communities that we care for in our primary service area have life expectancies of birth that are less than 70 years. In particular, this area number 37 called Fuller Park, Englewood, West Englewood, the Burnside community here, but again, mostly either dark gray or black areas that indicate life expectancy at birth being between 66 to 70 or 70 to 74. So our partner in this program in the Institute of Translational Medicine is Rush University, which is listed here, and they happen to exist in Area 28 here on the near west side of the city. And you can see that some of the poorest neighborhoods are just adjacent to that, including South Lawndale, Area 27 here, East Garfield Park, West Garfield Park, and I'm sorry, I misspoke here, North Lawndale here, which are communities that are here on the west side of the city, as well as the Austin neighborhood, which is shown here, which is adjacent to that community there. Again, you can see the discrepancies here for yourself in terms of life expectancy. Now, for those of you who are unfamiliar with Chicago, you may think that what you hear about Chicago a lot is a lot of the crime and violence that is in the city of Chicago, but we should probably take a look at what are some of the drivers here. This is a study that was done by the Chicago Department of Public Health in conjunction with its Healthy Chicago 2025 initiative. And this is data that was presented in 2018 and looking at the difference in life expectancy from Black, non-Latinx people who live in our community versus white, and specifically the 5 drivers of that gap. Now, although gun-related homicide is significant here, you can see that actually by almost a factor of 2 to 1, that actually chronic diseases are the driver of the gap that you see in life expectancy for these communities. And so again, older data, you may say, very interesting. I wonder what's happening now because of this 8.8-year gap and how has it been impacted, particularly after having gone through the pandemic over the past few years. New data also provided in the brief that I showed you from the Healthy Chicago zones just a moment ago. That gap has actually widened in that homicide in the city of Chicago has actually gone down in comparison to where it was several years ago, but chronic diseases have increased. And so that gap, particularly for Blacks and African Americans in the city of Chicago, has expanded from 8.8 years to 10.6 years. So fairly remarkable, but wanted to give you a sense of this is the environment in which we are working in communities and thinking about ways in which we can address translational sciences. I'm going to shift gears now and to talk a little bit about some of the work that we do through a program that I founded in 2010 called Community Grand Rounds in order to address some of the educational issues around health and well-being, and also to generate the ideas of around what our community members think are the primary health issues that are in place for their communities. And so, as I mentioned before, this is a program that is funded not only through the Institute for Translational Medicine, but also the University of Chicago's Urban Health Initiative, which is our public health and community arm of the University of Chicago Medicine. We have in these community events both community and university experts that sit in the same space in events that take place in community settings. The topics and venue and delivery format for Community Grand Rounds are driven by community representatives that we call community consultants that meet on a regular basis and talk to us about what kinds of issues are important to community members. The next ellipse there shows you some of the issues that we have talked about over the years, including mental health, community violence, which has been a perennial topic for us, asthma, diabetes, men's health, cancer screening rather, not screaming. We have a youth summit that has taken place every year over the past 12 years, actually, in which we have young people from a youth development agency to actually develop the community grand rounds themselves, as well as research ethics. Now, when we started this program in 2010, with the advice of our community consultants, they said, we don't want people from the university to come to talk to us. And their quote was, we don't want a bunch of talking heads to come to lecture to us, but we want to be engaged around topics and issues that address us in a way that is acceptable and relevant to what's going on in our communities, and to do so in a way that provides information to us that is acceptable. And so what we've done during these settings is that we have shown documentary movies. We've had a rap and spoken word artist from the community to develop original pieces of poetry and spoken word. We've had the daughters of a community jazz musician who passed away to present pieces of a musical that he developed in the 1970s called Journey to Forever for our work around or session around aging issues. We've also had people to come in from the community to do cooking demonstrations on how can you manage healthy cooking and eating if you have diabetes and you have to do so on a budget. In 2017, we added Pritzker medical students as a part of community grand rounds in which they provide online support during these sessions in terms of answering questions from community members. And then in 2020, we added our graduate medical education, so residents across the University of Chicago, into these sessions in which they provided both content support as well as facilitation of the discussion sessions that take place. We do these in various settings, and when I come to my next slide, I'll just give you some examples of that, but we've done them in schools, community education centers, churches, etc. Of the sessions that we've had over time, we've actually only done one on the University of Chicago campus. Because of COVID, we had to switch to a virtual format and did these sessions virtually over Zoom between 2020 and 2023. Unfortunately, without a drop in terms of attendance, and did this work in support with the support of our the Office of Community Affairs here at the University of Chicago Medicine. Over 60 sessions, over 5,000 participants. You can see that we evaluated the sessions using a Net Promoter Score. And not only have we done these at University of Chicago, but we've spread this to two of our other partners within the Institute for Translational Medicine, both Loyola and Rush. Interestingly, as a result of this program, and particularly the perennial topic of violence in the community, it spurred the creation of another program that we've been operating in conjunction with the Logan Center for the Arts on campus called WRAP, or the Wellness Resilience Arts Program. So again, really taking this model and translating it into a specific issue for the community and using the arts as a pedagogic tool for youth that are in the community. Promised you a few examples of places and people who participate. You may wonder, who are those people that are up in the upper left-hand corner of your screen that are bowing? These are actually community members who participated in an original play that I wrote on the issue of mental health and post-traumatic stress disorder and violence called It Should Have Been Me. It was presented as our first community grand rounds in October of 2010. At a local high school. About 140 people were in the audience and participated in this community grand rounds, and we had a follow-on discussion with a mom whose son was killed as a result of gun violence in the community, a child and adolescent psychiatrist who did work in the criminal justice system, as well as one of our investigators who was doing work in screening using an online screening intervention for depression in youth and South and West Side communities. As I mentioned before, we've also had other ways in which we have blended creative sessions in the provision of information around health and well-being based on the recommendations from our community consultants. I point to this setting here called the Clio Center, which is about 3/4 of a mile west of the University of Chicago campus. You can see a few folks that are walking in there. This was a session that we did with this gentleman here who his name is Ronald Holt. He's a Chicago police officer and is involved in community engagement. His wife is actually the chief of the fire department for the city of Chicago, and their son was killed in a drive-by shooting on a bus trying to shield a classmate coming back from high school. And he talked with our group here in community grand rounds around some of these issues. The person sitting next to him is a professor of social work here at the University of Chicago at that time, who did work in this space. And the young man sitting next to him was someone who had been involved in violence in the city of Chicago and actually was shot and paralyzed as a result of gang-related violence, who now served as a violence interrupter. This was done in conjunction with this gentleman here. You're maybe wondering, why have you got somebody that's on a turntable there DJing? And it's because we did this in conjunction with a program that was run by the Clio Center, Keep Loving Each Other, called Friday Night Live, in which they invited young people in to have a place where they could spend time listening to music, dancing, and DJing, and we decided to add on to that community-based program. This program, a picture that you see here in the center, is as I said, the only activity that we did on the University of Chicago campus, done in conjunction with a Hyde Park neighborhood organization that was promoting health and well-being for seniors in the Hyde Park neighborhood, and did that on campus with our University of Chicago students. The picture that you see here in the lower left-hand side of your screen was from our largest community grand round setting, in which we did it at a high school in the community after their after-school programs, in which we had over 200 people in attendance, youth and their caregivers, and it was done with the topic of sexually transmitted infection and teen pregnancy prevention. The participants in that program included a University of Chicago researcher who was involved in sexually transmitted infection prevention, as well as a young man who founded a project called the Dovetail Project that was aimed at young men being responsible fathers for their children, and a young 18-year-old young woman who was on stage with her 8-month-old, who also wanted to speak about her experiences as a teen mom. So again, topics selected and designed in terms of topics, venue, and participation with both university as well as community experts in this space. We had the opportunity to present this work as part of one of the ACTS meetings, looking at our community and university partnership as a poster presentation, and have had discussions around this project in a variety of other settings. I'm going to move on to my next topic here, which is how are we doing this work in conjunction with community partners through the Chicago Chronic Conditions Engagement Network. This is a project that we had funded, was funded through a P50 through the National Institutes of Minority Health and Health Disparities, as a prelude to the work that we're doing in developing a community engaged research network. And you can see the goals of the project here, identifying solutions to address the health gap in multiple chronic conditions with a focus on cardiometabolic health. We wanted to understand the role of the intersectoral factors, including neighborhood, SDOHs, social determinants, and mental health on the development of these conditions. But most importantly, and for the work that I do in conjunction with this project, is a way to engage our community partners in a meaningful way throughout all phases of the research cycle, as well as stimulating collaborations across academic institutions, clinics, and regions and community organizations, which I'll demonstrate in just a moment. This is our organizational structure. Again, center co-directors for this include Dr. Albert Wong and Professor Elizabeth Lynch at University of Chicago and Rush, respectively. These two people also head up the community engagement core for the Institute for Translational Medicine. And then these are the various cores that are associated with the program. I'll point to this particular group here, the Community Stakeholder Advisory Council, and we'll talk about their engagement in just a moment. As a part of this P50, we were asked to submit 3 R01s initially that were in partnership with community organizations, and then with a second issuance for a funding opportunity, we added 2 additional programs to this particular program. The goals of the Community Engagement Core are the following: to increase research addressing the priorities of communities, and then also, in particular, increasing our research partnerships and collaborations, both with community-based non-health related organizations, as well as healthcare-related organizations. Here's a listing of some of the community organizations that are involved in our core infrastructure. And you can see a listing here. I'd mentioned Advocate Aurora and Endeavor as being part of our organizational structure, through hospitals, through the Institute for Translational Medicine, as well as the academic institutions that you can see at the bottom there. But we also included federally qualified health centers that are in the area, that include Aunt Martha's, Chicago Family Access Community Network. Partnerships, and again, important in terms of our boundary spanning partnerships, as I mentioned, in terms of what's required in translational sciences principles. Chicago Department of Public Health, Cook County Department of Public Health, and also one of our adjacent suburban areas, the Kane County Department of Public Health, are a part of this community engagement core. And then community-based organizations that are facing the community and doing direct work with the community, including the West Side Health Authority, Interfaith Mental Health Coalition, West Side United, Alive Faith Network, the Greater Auburn Gresham Development Corporation, Pastors for PCOR, and so linking this a little bit to the Patient-Centered Outcomes Research Institute. Probably you're aware of that, and perhaps some of you have even received funding through them, as well as Phalanx Family Services, so direct service organizations that are serving various aspects of the community. You can see here how the Chronic Conditions Engagement Network and through some of these projects are engaged. The solid lines represent projects that have direct connections to these organizations, including things like Illinois Department of Aging, Mather Lifeways, or are working with them in a consultative basis. And so you can see here, West Side Health Authority, the Portal PTSD program working directly with Chicago Family Health, and then connections with the Chicago Department of Public Health. Equal Hope and the Alive Faith Network connected to the Keep It Moving project. And so again, a network bringing them into the Chicago Chronic Conditions Engagement Network and the engagement of community. And then again, as particularly with this, with the VITA project, Advocate Healthcare. Our Community Stakeholder Advisory Council is headed up by these three people. Dr. Tanya Roberson, who works as a community psychologist with the Phalanx Family Services. Sherry Pace, who is the Chief Executive Officer of Chicago Family Health Centers, and Pastor Steve Epting, who heads up the Alive Faith Network. I mentioned that we hold community town halls as a part of C3 in order to have, I think, a much more vibrant way of representing the work that we do and asking for community feedback. We hired a graphic facilitator to really listen to what we were saying in these community town halls and conversations, and to provide a graphic illustration of what was needed from the community. And so you can see here that some of the feedback that they wanted actions in front of words, so don't be performative. They wanted to have mini grants. They wanted to have mini grants with a community partner, and they wanted to make sure that there was a needs assessment and sharing results. Important to them was creating common solutions and how can we stack travel and our journey together and to do things rather than coming out of this siloed effect and a traditional segmented model of doing research. The question of the community voice being critical to understanding the context, and I mentioned this in the role and the goals of the Chicago Chronic Conditions Engagement Network, knowing what kinds of things were important in terms of context, in terms of access to resources, cultural issues, bidirectional communication, but also understanding that we were all a part of this big picture, and that we were interested in collaborating. I'm going to focus a little bit here on the issue of the mini grants with a community partner and how this evolved into a change in the way that we were providing grants through this program. Dr. Joyce Chapman was a part of our Community Advisory Council, Community Stakeholder Advisory Board until her untimely death in 2023. This is a little bit of her bio. She was a legend and a real rock in the South Side of Chicago in terms of the work that she did in development in the Pullman community, in the area of the work that she did around women's empowerment. And she actually was the president of the Quality of Life Planning for the far South Side of Chicago, which was funded through the MacArthur Foundation. She was a member of our Chicago Board of Education, as well as a commissioner of our Public Buildings Commission here in the city of Chicago. Her untimely death, literally, she went with us to our first national meeting for this particular initiative in Washington, D.C., and she passed away 3 days after returning from Chicago from that national meeting. It was within that framework and within the really exhortations from our community partners that we develop a mini grants program. And so we named that mini grants program for community partners after Dr. Choice Chapman. Her favorite expression in terms of engagement was, you've got to grasp in with your toes in order to get ready. But in order to get set to go, you've got to have one toe up. And so 10 toes down and then one up. This work has led to the development and really providing the background for a community-based research network within the Institute for Translational Medicine, in which we are connecting researchers and community-based organizations to partner around research with center pilots and mini grants that are started through this. We're looking at ways in which we can impact health outcomes through a shared framework for community-based research. We really are supporting the goals of co-designing these studies, both through the initiation of mini grants, as well as the continuation of this work through the pilot awards that are given to investigators through this work. And then we're also developing a shared database tool for researchers and community-based organizations for the purposes of partnering and driving community-driven research. I always like ending with this slide because I think that it really gives you a sense of the amount of engagement that we have historically within the city of Chicago. And not just historically, but also the ongoing work that takes place. Chicago is known as a place for music, a journalistic history through the Great Migration. The picture that you see up here in the upper left-hand screen is Dr. Daniel Hill Williams, who founded Providence Hospital and was thought to be the first surgeon to perform successful open heart surgery in the early 1900s, and actually performed this surgery on the south side of Chicago. And Dr. Daniel Hill Williams is also someone who's African American. But the other photos that you see here is that we also have a very promising and bright future as well. I believe I will stop sharing my slides there. And I think, Dr. Ritter, we may have time for about 10 minutes of questions before we adjourn. Is that correct?
Yes, that is correct. Thank you so much, Dr. Miller. That was a wonderful talk. I can check in the chat. I do see there is a question. So how do you measure crowded areas / households in the hardship index?
So this is primarily taken from the American Community Survey data in terms of crowded households, and we're using the national definitions and standards through the American Community Survey in terms of those measurements. Thank you for the other, this is an awesome program. You've seen it advertised in social media. Oh, thanks for following us. Thank you.
So if anyone has any questions, they can feel free to unmute or put the questions in the chat. I see another comment here. Amazing work. Thank you so much for this talk and impressive community engaged projects.
This kind of work would not be possible without the incredible involvement of our community partners. And so for any of you who are on the call today and you have some apprehension about partnering with community, I often say that this work is retail, and that community engaged research happens at the speed of trust. That's not an original quote. I picked this up from someone else, but the ability to establish trust with community-based organizations and to really be there for them when they ask, I think is just incredibly critical. It's not helicopter research, no. These are longstanding relationships that we've been able to develop with these community partners. And sometimes it's around research, and sometimes it's around providing support for community events and to show up for them as a university partner and supporting them in their work.
Oh, I see. Rini has just unmuted. Go ahead.
Thank you so much for your talk, Dr. Miller. I'm wondering how you're navigating the current times and sort of the way federal dollars are being reallocated to fit federal priorities and how the priorities are being realigned away from previous relationships that had been built. And I understand the there is a way that we can align ourselves with current federal priorities given the populations of the cities that we are in currently. But it is difficult to explain these things to the existing community partners and the trust, the relationships that you have built over time with community partners. So I'm just wondering how you navigate those relationships in the current landscape.
There's another story behind the Chicago Chronic Conditions Engagement Network and the P50 that I mentioned a moment ago. And so I'll just provide a little bit of context for it because I think that it speaks directly to your question. As I mentioned, we were funded for that program through the National Institute for Minority Health and Health Disparities. And actually, our grant was one of the grants that was canceled back in March. And we were enjoined in the American Public Health Association lawsuit and then reinstated with some changes in terms of the language that we used in our grant. However, when we had before we knew that we were being reinstated back in the summer, we had this initial conversation with our community partners in the spring to say, this is something that has happened. We're very sorry. We're going to try to figure out a way in which we can continue this work and to continue working with you. But we hope that if you decide not to, we hope that we will understand. And our community partners shrugged their shoulders and said, welcome to our world. We are at the mercy of soft money funding in order to get our work done on an ongoing basis and have experienced this. We remain committed to the goals that have been put forward in this project and let us know how we can help you. And so I think that the reason why they were able to really step forward in this way is because we had established long-term partnerships with them prior to applying for the P50 and then asked them if they wanted to come on board and to join us. And so again, these relationships happen at the speed of trust. And the trust that had been implemented had been trust that, at least from the work that I was doing, went all the way back to 2010 with this particular program. And so when the grant was reinstated with some modifications, including a change in our name to the Chicago Chronic Conditions Engagement Network, our national program office at the University of California, San Francisco is now known as the Health Excellence Action Network. It's been that our work is aligned with the institutional priorities of the current federal administration. We are focusing on ways in which we can decrease the rates of cardiometabolic disease and the things that surround it. But we have had to, again, realign the way that we speak about our work based on current federal priorities. Thank you.
Thank you.
The question in the chat, what advice would you give to current public health students? Please, please, please stay the course. I know that with the current changes that are taking place within federal priorities are sometimes challenging. We need you. And I think that one of the things that, if nothing else, that COVID demonstrated to us is the incredible importance of public health and the need for not only public health infrastructure, but engagement of communities, engagement of education in terms of how people responded to the pandemic. I was very fortunate here being in the state of Illinois that we had a very strong public health infrastructure, both at the city and county level, as well as the state level. And we were able to initiate rapid response teams in order to provide assistance to communities, underserved communities that had disproportionate rates of COVID-19 infections. And in fact, were able to, in many respects, turn the tide because of the engagement. And the engagement, I'll just expand on this a little bit, happened across sectors. And so The University of Chicago is a private institution, but we sat on one of those rapid response teams in conjunction with the Chicago Department of Public Health and Rush and the University of Illinois at Chicago and other organizations in order to provide support for our local communities, even though we're a private institution. But we took our role as particularly in the Urban Health Initiative, as the community extension arm very seriously in helping to support the health of our communities. And so, again, glad to hear about public health students. Hang in there. Your work and your dedication is so needed. So workforce development regarding research of community partners. Great question. Part of the work that we do through our Community Advisory Review Council is actually the provision of educational development in this space, but we also work with community health workers in this space as well, and we provide some training through the Institute for Translational Medicine in partnership with our community college, which has a focus through the city colleges of Chicago on training community health workers, and we provide curriculum through the Institute for Translational Medicine on how community health workers can be trained in some of the basics around research and research ethics, and really underscoring their role as being very critical in that tie between what we do here as investigators in the university and the work that they do within communities. And so that's been part of the work that we've done. In addition, we've worked with the University of Chicago is working with Malcolm X College to provide training to community health workers through a site that's being developed here on the south side of Chicago. I think maybe we've got time for one more question, Dr. Ritter, if there's one there.
Yes, if anyone else has a question, feel free to put it in the chat or you can ask directly. As people are thinking of their questions, I can share a slide here. So this is a CME hour that's available. So you can claim your credit by scanning this QR code and then using the code here, 78080. If you don't have an opportunity to do this right now, you will also receive this via email so that you can do this at a later time. I was just checking the chat. A lot of comments about how great the presentation was. I don't see any other questions. And then I have one last slide to share. So then the QR code on the left is a way that you can register for all of the upcoming Distinguished Speaker Series. Next month is Dr. Emily Pfaff from the University of North Carolina at Chapel Hill. This is on November 20th at noon. And then the right QR code is to become a member with the CTSC and stay up to date with all of our ongoing events. I am not seeing any other questions, so we will end the session here. Thank you so much, Dr. Miller. I appreciate you taking the time to present.
Thank you. Pleasure being with you today.